Good afternoon and welcome. I'm Christy Newton, co-facilitator of the TBC at UBC Network, and I'm an associate professor and associate head education and engagement in the Department of Family Practice in the Faculty of Medicine at UBC. Today, I'm joined by my TBC at UBC Network co-facilitator and clinical associate professor in the midwifery program, Lee Yates. And thank you all for joining our first TBC at UBC Network event. Before we start, I would like to acknowledge that UBC's Vancouver Point Grey campus is situated on the traditional, ancestral, unceded territory of the Musqueam people, and that UBC Okanagan is situated in the territory of the Silks Okanagan Nation and their peoples. I would also like to recognize that UBC's activities take place on Indigenous lands throughout British Columbia and beyond, and that you are joining us today from many places. And I acknowledge the traditional owners and caretakers of those lands. I am attending from Port Moody, the traditional unceded territories of the Quequitlam First Nations. And please feel free to share the lands from which you are attending in the chat. I'm now going to hand it over to Lee to introduce and describe TBC at UBC Network.
Thanks, Christy. The TBC at UBC Network is building on collaborative initiatives that have been taking place at UBC over the past few years to contribute to broader provincial efforts aimed at advancing models of team-based care. This network has been launched to support team-based primary healthcare transformation in BC, with a particular focus on education, research, evaluation, and knowledge translation. The network aims to create a generative space that brings people, needs, and ideas into relationship. It will enable you to discuss and learn from each other about on-the-ground needs, opportunities, and challenges regarding team-based care design, research and evidence, pedagogy, policy, and integration. The TBC network is supported by UBC Health, which works under the Office of the Vice President Health to help address complex challenges affecting the health and well-being of individuals, communities, and societies. UBC Health facilitates collaborations across disciplines, across faculties, external partners, and communities to improve the ways we train people, develop knowledge, and shape policy, and ultimately addressing inequities and improving the systems that foster and support health.
So today's TBC at UBC Network event was specifically organized to highlight some of the work that is currently being done within UBC to support team-based care. So we have a panel, and our speakers are Morgan Price, Director, and Sarah Fletcher, Research Manager at the Innovation Support Unit in the UBC Faculty of Medicine. Nelly Oelke, Associate Professor at UBC Okanagan School of Nursing and Scientific Director at the Rural Coordination Center of BC. And Brenna Lynn, Associate Dean, and Sarah Tajani, Learning and Curriculum Manager at UBC Division of Continuing Professional Development in the Faculty of Medicine. After the presentations, we'll have a panel discussion around the types of questions that our presenters think remain unanswered and how the TBC at UBC Network might contribute to finding solutions given the role of UBC in education and scholarship. All participants of the webinar will also have an opportunity to ask and provide solutions to questions. So I'm going to hand it over to Morgan for the first presentation.
So I think the best introduction to our primary care innovation support unit was by somebody at the GPSC, which was we're a unit that supports innovation. And then he kind of realized how circular the definition is, but that's exactly what we do. We were set up to work in primary care from UBC to help with different aspects of the changes that are happening and seeing where we could uniquely add value from the university. So we take a general approach of engaging with partners in the community or, in the system and understanding where there might be needs or opportunities to help. And ideally from there, developing some tools that do help. And if those are successful, spreading those across the system. So it's an iterative I don't want to use the word prototyping, but a testing approach to building tools and services that can help facilitate change, improve evaluation, etc. We started in 2017 when Christy and I were co-heads of the Department of Family Practice, where we had an idea, a glint in the eye, if you will, and we applied for a SIF grant within the Faculty of Medicine, and we were lucky to get that. And then Sarah Fletcher joined us in the beginning of 2018, and we sort of embarked on 4 different ideas, a couple related to evaluation and a couple related to engagement, supporting teams in practice to understand how they want to work together, and then also running a small community of practice. And from there, we've expanded and done a lot of work, and this is not to be read, of course, but at the very bottom, there's TBC at UBC. We were part of the group that originally started this in, it's hard to believe it's way back in 2018. And TBC at UBC has grown quite a bit since then. Today, in the few minutes that we have, I just want to cover 4 areas that we're working in: implementation support tools, learning cycles as a method of how we help to foster a learning healthcare system in primary care evaluation, and then TBC advisory, or team-based care advisory. So our implementation support tools, these are really designed to actively help teams become teams and networks become networks. And we started with team mapping. And this really was a facilitated workshop that allowed clinical teams to figure out how they wanted to work together. And by working together on how they wanted to work together, they became more of a team. And then the flow of care started to work better. This is a rapid, short, could be done in a sort of a lunch and learn session or a series of lunch and learns to help the team work together. And from there, we discovered a need in communities to help the primary care and community care work together on how services could be delivered. So we kind of expanded our viewport from one clinical team to a community or a network. And we supported groups thinking about how they can better provide mental health and substance use services in a community, access to primary care across the community, better support patients with frailty or youth with complex needs. More recently, a little thing called a pandemic, we've been developing an immunization version of PAC that's been supported by the Public Health Agency of Canada. And then also just to help with general primary care network planning. How do they deliver support services and how do they deliver services across the network? Our second concept that I'm going to just flag here is our learning cycles. Thinking of this as sort of dipping toes into the learning healthcare system. And essentially what we've been trying to do with these is work in an iterative process with stakeholders who have questions or are about to make decisions on potential policy changes or wanting to understand how a particular piece of work has landed and how they might adapt in the future. So our very first cycle was after the first wave of primary care networks. Service plans were submitted, and the ministry wanted to understand how it went and how they could improve for the second wave of applications. So we were able to squeeze in Sarah's probably remembering a 6-week or 5.5-week learning cycle over the Christmas break. Over the Christmas break. I'm having PTSD. To understand what worked and what didn't, and then propose what could change. This is one of those moments as a researcher that was a lot of fun because 5 days later we saw policy shift. And the wave 2, which launched the next week, actually had things that came out of our learning cycle embedded in it. So we very, very granular, some of those changes and small, but had an impact on the next wave of PCN applications, which was great to see. So they're learning cycles. They're meant to be sort of 6 to 12 weeks, a particular question, a focus on that, and landing on what we call a constructive workshop. So not just to say, oh, we found out 7 interesting themes, but let's take one of those themes and let's work through it to see how we can actually make an improvement and then encourage that improvement to be adopted. And we do that with our stakeholders, be it in a community, be it within sort of the palliative care community, or be it within a ministry division. So that's one of the other pieces of work that we've done. And then evaluation. So we try to balance this. I just came from an evaluation meeting just now, the sweet spot between what's feasible and what's meaningful. And early on, we started to look at the literature. And as any good team, we developed a framework. And we've revised this framework multiple times now. We're sort of on our third iteration of this framework. The team framework includes 10 different dimensions, from patient and relationship-centered care in the middle, all the way out to healthcare costs and the health of the population on the outside. And this gives a breadth of concepts to think about when considering how to evaluate changes in primary care. We've actually gone through recently the literature for the third time to look for other frameworks and then map those back to actually across each of them, and then come back to see what we might have missed and enhanced our framework. The other thing about the team framework that we find is really important is to remind folks that while some of these concepts are really important, we can't always measure them in a quarter or a fiscal. And that's a conversation that we often have with decision makers, where they have certain timelines where they have to make decisions. So we've embedded an adoption model into this to remind people that those outcomes around preventive care, improving mortality, aren't going to happen in a quarter or even by the end of this fiscal. That's going to take years and years. So let's measure them as a baseline, but let's also measure other pieces of impact, from engagement to behavior change. And then some of those early indicators as the system gets implemented, rather than expecting by March 31st to have some significant clinical outcome, when that's not necessarily realistic. So this has been helpful to shape some of those early conversations with leadership. And then the last piece of work I want to highlight is our work closely with the Provincial Team-Based Care Advisory Committee. This is chaired by Natasha Prodenbala, who is the Chief Nursing Officer for the province, and she leads this multi-stakeholder group that meets regularly to look at what some of the needs are as we transition from our current way of practicing in primary care, the addition of our primary care networks, and moving into more of that truly integrated team-based practice that some of us are lucky to practice in, but it's not equal across the province. So we have, through the ISU, worked with Natasha and the group to facilitate a number of different pieces of work, some more mundane things like websites and content for websites, to also think about what are some of the strategic important gaps in the system right now that will need to be better supported to enable change. And we're working closely with the BC Patient Safety Quality Council, as well as many of the other stakeholders in the committee. And this is our placemat of things that we want to move ahead, the what's that came out from the advisory. And this is broken down into 4 levels, from the individual person who's involved all the way up to the system, and then looking across from sort of that early engagement all the way through to sustaining the change. And those 4 categories conveniently align with the adoption model that we have previously. We have also talked about thinking about the support system around around change. And at the bottom of this diagram, we look at groups that are developing new evidence-based approaches. So we kind of see the ISU and many of the folks at UBC in this space, looking at the evidence and how can we apply that to make a change, and then leveraging this large provincial collaboration that exists with our different partners to try to spread that into community and through the different networks. And then in order to make that actually happen within a community, I think what's critical, we know even more today with our lack of capacity for change after this last, I think Bonnie Henry said it was getting close to 22 months of massive change in primary care and throughout the whole healthcare system. We do need that local support. We need that active support at the elbow to help clinicians and teams change. And so all these pieces need to be there for this sustainable system. And then that feedback loop, of course, that evaluates if that change is an improvement and if that improvement can be further enhanced. I'm aware of time, and I'm going to jump to my thank you slide, and I'm going to stop there. So thank you, everybody. And I'll look forward to questions afterwards.
So I'm Nelly Oelke. I'm with the School of Nursing at UBC Okanagan, as well as Scientific Director for the Rural Coordination Centre of BC, and also a member of the BC Primary Care Research Network. And so I'm going to be talking about a research study that was supported by the network, as well as CIHR Michael Smith Foundation and UBC Okanagan, the Provost Office. So here is the team of the researchers with this project. And you can see that it spans 4 different provinces in Canada. So just a bit of background is primary healthcare teams have obviously been implemented in various ways across Canada. And even so, the impact of primary healthcare teams on outcomes, including integrated services delivery, is still mixed. And, there is limited good evidence. There's good evidence in certain areas, but less evidence in others. And so because of the little evidence on what policies and structures actually could facilitate, incentivize, or actually promote integrated service delivery for this population, we looked at a population of adults who had 2 or more chronic conditions. And then we did this policy analysis, as well as some interviews and deliberative dialogue in 4 different provinces across BC, or across Canada. These were the research objectives: to identify policies and structures to facilitate the development, implementation, and sustainability of team-based primary healthcare models, to look at performance indicators used to measure integrated service delivery, and then to ascertain how policy structures, roles, governance, and performance measures supported or acted as barriers. We also looked at what were some of the unintended consequences of policy. And then finally, we also did a sort of a parallel piece looking at specifically how patients, broadly defined, were engaged in policy development and implementation for primary healthcare teams. So it's 3 phases of the study, and do know that this study started in 2017, is still going just because of COVID and the disruptions. So phase 1 was an individual and cross-case policy analysis. We looked at both provincial and regional level policies. Then we looked very specifically at patient engagement in policy development, implementation and evaluation, and then are still working on finalizing a national interactive KT event. So these were the results that we found from our policy analysis. Persons under care and engagement of patients were definitely key components of what we found in the policies. The patient partnership and creation of policy was there. What we didn't see is the continuation of patient engagement in policy implementation and evaluation. There was significant variation in how patients were engaged. There certainly was a lack of clarity on patient engagement. So, it looked like they were there at the beginning, but not following through. And then certainly we saw a more specific component with First Nations Health Authority in BC and the engagement of them. And then Ontario's patient engagement through Lynn's and now the Ontario Health Teams. Team structure, it varied across the provinces and included both co-located and virtual teams. The mix of professionals and skills locally was responsive and meant to be responsive and appropriate for the population, although it lacked information on how that population needs were determined. And Alberta specifically recommended a 3-to-4-to-1 ratio, whereas although most teams still have that 1-to-1 ratio. And the common barrier that was raised was around optimal scope of practice and clarity of roles. Information systems was another theme that came out quite significantly. Certainly lack of interoperable systems is what we see for the most part. Quebec and Alberta have invested in single systems, and we have electronic health records were acknowledged to be key in providing continuity of care and improving communication between team members. And that's even more important when we look at virtual teams. And then EHRs have the potential to increase ways to communicate with patients as well. Financial management, there was no single compensation model for all primary healthcare teams. Remuneration models essentially were not addressed in policy documents. And if what models are out there oftentimes can be counterintuitive to team-based care. Policy showed early consideration and development of more innovative funding models for primary healthcare teams. And we need clear guidelines or recommendations for funding primary healthcare teams. This was very limited in the policies. And finally, performance measurement. There was an overall lack of focus on indicators and measurement. Nice to see the evaluation framework, Morgan, coming to fruition. This was done probably before some of that work was finalized. Provinces that had more advanced primary healthcare reform definitely had more emphasis on evaluation. And so in Ontario, we saw policy documents focused on prevention, screening, and compared models within the province. And Alberta focused on measuring emergency visits, chronic disease management practices, and medication prescription patterns. And essential to performance measurement was a functional interoperable EHR. So in conclusion, there was a lot of variability in the models of primary healthcare as well as teams as well. The challenges aren't new. These are things that we've heard, time again, and continue to be those significant issues that arise. There's a significant gap in performance measurement. Patient engagement policy has moved in the right direction, but there isn't clarity around the processes that are needed, and particularly across the spectrum of the policy process. And there's a need to address integration beyond the individual team level to integration within the health system. And then given the move to more virtual care, we definitely need to focus more on integration within and beyond virtual teams. And this is just a manuscript that is in press on our results. And just in conclusion, a few further studies that we're working on and evaluation of the integration of primary care nurses in BC, particularly focusing on training and education, and then exploring and the development of a primary care nursing certificate program or micro-credential courses for nurses to be able to be appropriately prepared for practice in primary care. And then recently just received a grant to look at team culture of primary care teams that will be focused in Northern Health and in Interior Health. I will turn it over to Brenna and Sarah.
So I will start us off here, and good afternoon, and we're pleased to be here as the last panel presentation, and we're going to discuss more about how continuing professional development, or CPD, is supporting team-based care. Next slide. So before we introduce ourselves, we'd like to take a moment to acknowledge that the UBC CPD office is situated on the traditional, ancestral, and unceded territory of the Squamish, Tsleil-Waututh, and Musqueam nations. So just introducing myself, I've been the Associate Dean of CPD since 2014, and I'm passionate about effective, customized CPD that supports continuous quality and practice improvement for both individuals and teams. In furthering these goals, I'm also a board member and Secretary Treasurer for the Health Data Coalition, previous chair and member of the Practice Improvement Hub, which I'll discuss more in the coming slides. I've worked with UBC Health to better understand the landscape for CPD in supporting team-based care provincially. And I believe that the BC healthcare system should be a learning organization, and organizations need to work together more effectively to further common visions and better use available resources. And now Sarah will introduce herself.
Thanks, Brenna. Good afternoon, everyone. I'm really thrilled to be here with you all today. I'm Sarah Tajani. I'm a Learning and Curriculum Manager over at UBC CPD. In my role, I partner with leaders in healthcare to lead the design, development, and improvement of tailored education for healthcare professionals and their teams. I particularly have a special interest in patient-mediated CPD and team-based care, and I really attempt to work to ensure that these important themes are integrated into our education. I'm passionate about lifelong learning and very much strive to facilitate positive change in continuing health profession education. And I also want to take a quick moment to thank the organizers for inviting us here today to participate in this forum. And back to you, Brenna.
Great, thanks, Sarah. You can go down to the next slide. So just setting some context, in the last 20 years, the field of CPD has undergone a massive paradigm shift in that the focus has moved away from knowledge acquisition and didactic delivery to be more focused on active learning and healthcare outcomes. So at UBC CPD, we're a unit in the Faculty of Medicine, and we're focused on lifelong learning and heavily involved in moving the field forward through bespoke approaches to CPD, such as coaching and mentoring and learning concierge. As an academic CPD program, one of our values is to be a learning organization with a focus on practice and quality improvement, and influencing the BC healthcare system to also be a learning organization. In many of the CPD initiatives, we've been working across organizations to further this goal. And now I'll talk through an example of this. So I want to share an example of how we are working across organizations and presenting the Practice Improvement Hub. So the PIH, a short form, was created in response to the need to improve access for effective physician and healthcare team practice improvement and quality improvement tools and supports. It's about coordinating resources in a collaborative manner rather than creating silos or duplicating efforts. And ultimately, we aim to improve physician and team practice to enable better healthcare. At the core of our work, the PIH Forum is a unique table that brings together and connects organizations and individuals to practice and quality improvement by sharing best practices, learning about and amplifying activities of other organizations, leveraging each other's work and aligning efforts, and exploring opportunities to collaborate around common areas of interest. This is in its 5th year, and it previously evolved from the CPD Hub, which was established in 2012, and we're making strides through trusted working relationships and agreement to a common goal. We have 4 strategic priorities. We have an anti-racism and cultural safety and humility working group, and a coaching and mentoring as a priority, data repository, and virtual care. While these have been identified areas of focus, it's important that the forum remains open and flexible to explore other potential priorities as they emerge. Most recently, team-based care, particularly in the context of the patient medical home and primary care networks, has been a notable topic of interest across the PIH organizations. So recognizing that the TBC advisory group that Morgan mentioned is leading the work in this space provincially, we recently engaged with them to learn more, find synergies, and discuss potential collaborative opportunities. Next slide. So the PIH Forum's membership is made up of 24 members from 11 provincial organizations. The membership consists of organization strategic leaders and operational leads to enable decision-making and action in order to make a difference on the ground for physicians and healthcare teams and ultimately patients. There are many more organizations on the working groups, and some of these include FNHA, Center for Collaboration, Motivation, Innovation, Pain BC, and Pathways. And I'll now pass you over to Sarah to present another example of initiative underway at UBC CPD.
Great. So Brenna's done a really nice job in outlining the power of working across organizations to facilitate practice improvement and quality improvement. So today I thought I could focus us all on an example of these principles in practice by taking you through one of our recent projects in partnership with our long-standing partners, the Vancouver Division of Family Practice. So within Vancouver, the Division of Family Practice is supporting the establishment of 6 primary care networks, PCNs for short, and I will be deferring to PCN. A quick reminder that PCNs are a clinical network of service providers who are located in geographical areas where patients receive improved access to primary care. By using a coordinated team-based approach, patients receive better care and linkages in specialized community service programs. So as these PCNs develop, the Vancouver Division has partnered with us to support its members in establishing and benefiting from the best practices in team-based care through access to tailored education, tools, and resources. And as we have started this journey, considerations that we've have taken into account are practice realities, embedding opportunities for quality improvement, and then the sustainability of these practices. So we recognized early on in the project that our objective would be difficult to achieve in isolation. So we drew on the principles of collective impact to facilitate sustainable collaborations and achieve impactful change. For those new to the concept, collective impact is defined as a group of stakeholders in different sectors committing to a common agenda and to address a broad, complex social change. The key stakeholders who are listed here were brought together to better define how we would work together. An agreement was created and then actually physically signed by each of the members of the group to demonstrate their commitment to our mutual vision, a shared measurement, and a joint plan of action outlining the roles and responsibilities. So ultimately, the role of this group is to provide insight into practice realities and dynamics, share knowledge of complementary initiatives, and support learners after the series to apply their learnings in practice by engaging in quality improvement work. We hope that by facilitating relationships between these organizations, that we are really setting up a process for mutually reinforcing activities. Also, that organizations involved will feel empowered to continue the work and enable ongoing supports to sustain successful team-based care in Vancouver. And then the final note I'll make for this slide is that as a facilitator of relationships, UBC CPD really serves as the backbone support to provide the coordination of the project and ensure continuous open communication to and by the participating organizations. So the principles of collective impact really set the tone for the education design and development, and now we needed to run with it. So once again, using a team-based approach, we brought together a working group to support the design and development of the education series. And of course, we encountered a few challenges along the way, which I'll be sharing with you today, as well as some of the solutions we implemented to kind of help us out through those. So the first challenge really focused on the working group that we brought together to support the design and development. We thought it would be great to mimic the makeup of a primary care network. There are, however, important perspectives that contribute to effective team-based care and practice that are not currently represented in the PCNs. So though we wanted to ensure all the relevant voices were heard and used to inform the education, we also needed to recognize that the working group itself needed to be nimble enough to support our timeline. To remedy this, we utilized other points in the process to engage important voices. So for example, at the needs assessment level, we engaged with key stakeholders. Another example of this is once we were getting at the point of reviewing the content outline of what the plan for the education was going to be, we engaged with MOAs, office managers, and physical therapists as well. Our second challenge really focused or revolved around the PCNs not fully being established yet. There's a lot of work that's being done by the health authorities, by the divisions of family practice, and therefore the PCNs are continuously evolving. So a big question for us was, how do we ensure that our education is flexible enough to accommodate the variations from group to group? Here, we decided to use a continuous bidirectional communication method with organizations included within our collective impact group that I mentioned earlier, as well as others that have been vital to ensuring everyone is really being kept apprised of the progress and ensuring that we're better aligning efforts to promote and support team-based care in practice later down the road. So a couple of examples of this are the Vancouver Division of Family Practice has steering committees dedicated to the PCNs. And so we reached out to them. We had them actually help to inform the education as well. And then we've also been having ongoing communication with the BC Patient Safety and Quality Council, who have been instrumental in kind of helping us to link and inform resources. Okay, so the third challenge, I'll go through this a bit quickly, just cognizant of time. With a working group of 10 independent perspectives on team-based care, the prioritization of topics was anticipated to be a challenge. It was really important to us that the education honored both the primary target audiences needs, but also ensuring that it was going to be meaningful to other healthcare professionals who may potentially take the education as well. So this was accomplished by setting ground rules in our working groups to ensure that a safe and respectful environment was created. So in the end, we landed on an education strategy that really highlights these key areas of practice. And that was something that all of the healthcare providers said that they agreed on and wanted to prioritize. So that includes identifying the team, understanding roles, developing common language, effectively communicating, and then integrating these principles into practice. So as of right now, content development is underway for a flexible delivery model, which includes options for virtual and or in person. And then this education can also be for smaller groups and also for larger groups. So just wrapping up, based on the conversations we've had with a multitude of organizations, of folks that are dedicated to implementing and supporting team-based care, we've really seen that there are 4 key areas that are needed to be taken into consideration to ensure a successful and sustainable model of team-based care in practice. This includes a shared provincial vision that has been informed by participating partners and stakeholders to gain buy-in and build awareness. The second being common definitions and consistent language to create an understanding between providers of what defines a team, what is a PCN, and what team-based care means within the context of a PCN. The third is a clear outline of the practical and residual benefits afforded by participating in team-based care, in a team-based care model of practice. And the final being making connections to support alignment amongst stakeholders around the province who have a distinct role in executing the vision and translating knowledge. And additionally, these connections can help to facilitate better sharing of data to actually measure the impact of educational interventions on outcomes. I'll pass it over to Christy and Lee.
That was great. Thank you, everyone, for sharing some of the great work that is happening to support team-based care in your arenas. Looks like we have 10 or 15 minutes remaining, and I'd like to open the room for discussion. I'll ask the panelists to start us off and invite folks in the room to share thoughts and ideas, either in the chat or if you wouldn't mind using the raise hand feature in Zoom, that'll help us see you. And for the panelists, I'm curious what type of questions you think remain unanswered or what's needful to address, and how, given UBC's role in education and scholarship, might the TBC at UBC Network contribute to finding solutions for these questions?
Perhaps I'll start out, Lee. I think in my presentation, I highlighted some of the things that do continue to need to be addressed. Funding models, definitely performance evaluation, as well as looking at electronic health records and having that common base to be able to share. How can we address those through UBC Health? I think to continue to advocate for those things, to support research that would help to answer some of those questions. And so I think that's a start.
Morgan?
Thanks, Lee. I'll just build on what Nelly said. I think I agree. I think there's a lot of pieces of knowledge that we have from our various research and research of those, in the academy more broadly. It's getting that to the point of implementation that I think is another area to think about. Is there's a lot of change in trying to understand where those changes are being decided and how to insert the evidence to help navigate and inform those decisions. That obviously that's where we try to situate the ISU, and Sarah and I think sort of came into that with that intention. But that's where I really see it's almost like adherence to evidence-based care. It's you can have the best evidence, but if you don't follow it, we want to figure out how we can help make those decisions or embed the evidence into decision making. I think that's important.
Thanks, Morgan. Brenna?
Yeah, just to add on, I think Nelly and Morgan started us off really well. From my perspective, I think, and we talked about it, is that cross-organizational mandate. This is kind of complicated work, and I think UBC Health can play roles around the research and scholarship around team functioning and best practices for that, because I think a lot of the partners in the community would be looking to UBC to play that role. I think in terms of groups like the Team-Based Care Advisory Group, I think they really need to start with common language and to have shared principles of the vision of team-based care. But I think we really need practical solutions, practical approaches, and I think we really need to have that bidirectional communication with the grassroots in terms of how this is operating and how this is working in specific locales. So those would be the points that I think are important in responding.
Thanks, Brenna. One of my thoughts when you talk about common language is how can we build a common understanding even of what we mean by team-based care? So are there any other, so it's a food for thought, I guess, and any other questions from our participants? We have a few more minutes for questions.
Hi, it's Lynn here from UBC Health. I actually have a question about whether there are opportunities for pre-licensure students to learn in and from some of the existing and emerging models of team-based care.
Do any of our panelists or even our participants have any comments on that? I see Donna's hand. Is that related, Donna?
Yes, it's somewhat related. I was going to sort of follow up on Brenna's comment as well. When you say where UBC can make the linkages, one of our big group of stakeholders is what Lubna's referred to, our pre-licensure students, right? And so do you have any thoughts or ideas around the education around team-based care, whether it's landing on a definition, still promoting our CIHC interprofessional competencies, the whole notion of getting our students to learn with, from, and about each other, not just in the classroom, but also on their apprenticeship, placement models. We're trying, and getting again more help and pragmatic assistance from your very wide-reaching stakeholder groups. It would be interesting to see how. I'd like to see and understand how the TBC at UBC is going to continue to interface with the larger TBC provincial group. Not sure I helped with answering any of that question, but it's wonderful to have this opportunity to know that we're all in this together, and it's good.
And that, as our first event of the network, the idea is to generate questions, think about questions, and what our specific, like, individual roles might be, and then the broader role of the UBC community. And then we're hoping to meet again in a few months, and perhaps the next panelists will be able to provide some solutions to those questions that are generated, and perhaps they'll generate more questions.
Yeah, just commenting on pre-licensure, students, we obviously at UBC Okanagan have a fairly large nursing program. We run around, this year we took in 172 students first year, so quite a number of students. And, we talk about team-based care in numerous different areas. We are in a situation, of course, other than maybe some social workers, which are very limited. We don't have a lot of access, and med students, again, a small number, that don't have a lot of access to different professions on campus. So, again, I think there's room for growth in that area. One of the challenges has always been, how do we actually, because of different schedules, how do we make it work so students can actually work together, learn together from different professions? So lots of work to be done there yet.
Not unrelated, Christine Bradstock asked the question, what do you envision the role of allied health to be, and who is helping to frame this part of your work? I guess that's just open to all of the panelists.
I think it's a good question. I can speak from the PIH example, and maybe Sarah, I think you can speak from Vancouver Division. We are focusing on physicians and teams, but we realize that pursuit of involving patients, nurse practitioners, the allied health professions is the important next step. For the PIH, it was really important to not have a massive advisory committee, but to have people that were ready on the ground to start something so that we could learn and then expand and scale from there. So that's been our approach. It has been very physician focused, but recognizing that the expansion is the future endeavor. And I don't know, Sarah, if you want to bring up some from the Vancouver Division project.
Yeah, sure. Thanks, Brenna. And thank you for the great question, Christine. I think from what we've learned, allied health have a very key role to play in this work. And I think, allied health and physicians and any other folks that are part of team-based care really have a responsibility to bridge the gap between themselves and the gap in knowledge that they have of other health professions and what they can offer. And so I think, really coming to the table and having those conversations and starting to understand each other's perspectives is a great place to start and really start building that common language, consistent definitions, those kinds of things.
I'll just jump in and build off that. Sarah's did it in the chat. That's our original work around team mapping was exactly that, to facilitate around a person, around a simulated case, how you work together and how you want to work together. And through that you go, oh, I didn't know that physiotherapists did this, as opposed to a bunch of doctors sitting in a room deciding what social workers do. The conversation is so much better when a social worker and a nurse and a doctor all talk about how they want to work together, and the MOA says, what? I could do that? How do I get upskilled to do that in our practice? And it's really hard in a busy, particularly fee-for-service, but in any busy practice that's not used to working together as a team, to create the space to have that conversation. And that's where some facilitated tools are really important to actively help make that change. So we've tackled it at the level of the team having those conversations, but there's all those, community and system level pieces that need to happen as well.
Mark has a question for Nelly. In your work, have you come across some insights on whether structural changes in PC have changed PT trajectories with ongoing chronic conditions?
Yeah, I did respond in the chat, but I think there has been some wins, absolutely, in bringing people together and starting those conversations and building those teams. But I think there still has to be a stronger integration of individual teams with PCNs and then the broader system, as Morgan was talking about in his presentation. So again, we're moving in the right direction. And, in some areas better than like demographic type and some geographic areas better than others. So I think we just have to continue to learn and move in that direction.
Was wanting to follow up on Morgan's comments, and we're hoping from the university that our next generation of practitioners will be in a room together and understand what each other does. Like we're really trying to do that, and we're super proud of what we call our integrated curriculum, where we feel we've been fairly innovative with one of our curriculums where we've actually built in primary care as sort of the anchor to bringing, thousands of students together around with a real live patient, not a patient case, and to sort of see if the students can figure out how their very basic understanding of primary care, could assist or be beneficial for the clients that are part of this session that these students are attending. So we're really, one of our prime goals is to make sure that our next generation of practitioners does understand the role and scope and understand where they might share some scope and to learn from each other and when they're out there. But it's back to sort of Nelly's point as well. It's getting these individuals into these teams and figuring out and using your tools and processes, I think will be a great start.
Got my eye just on the time. One of the things when we do webinars, I find is the conversation sometimes a little slow to start, and then once we really get underway, we have to start to wind down and slow down. So I want to take a minute. We have one slide left. I'm going to ask Veronica to put it up. And while she's loading that, I just want to thank everyone for joining us today for our launching event and extend a particular thank you to our panelists. And so we would value hearing what your key takeaway is from today's session. Using the annotate feature in Zoom. Veronica's put the instructions in the chat. If you could take a moment just to drop a word, to share a word, a concept, an idea, or even a question on the slide. If there's something else you want to see down the road too.
I would like to also extend a thank you to our panelists for sharing the great work that they're doing to support team-based care. And I know that for them, that was probably just part of what they do every day, and that we could be here for several other hours hearing about their other projects and other work. But that's for another day. As I said earlier, we're hoping this is just the start of an ongoing discussion and setting a network type table to support broader provincial efforts to advance team-based care. We have set a date for our future meetings. So we will have another event set for February 9th, 2022. So this is your formal save the date. And we will send a save the date to all of our participants as well. But February 9th, 2022, same time, and perhaps a little longer, or we may extend it, because as Lee says, once we get started, it's a shame always to have to wrap up a conversation right in the middle.
Thank you, everyone. I look forward to, and I think Christy and UBC Health, we look forward to continuing the conversation and seeing you down the road at our next webinar. And certainly if anything comes up or you have any questions, don't hesitate to reach out to us.